pleasure to be at the conference and to be in the wonderful Barcelona. So today I'm going to talk briefly about the relationship between the use of psychotropic medication and sexual risk behaviors. So in the United States, we have the dubious distinction of being a society where we have a high rate of incarceration as well as a high prison population. In the United States, we have quite a few adolescents who are in juvenile detention facilities. And theoretically, these facilities are meant for rehabilitation. In effect, we know that sometimes very little rehabilitation takes place. But among detained adolescents, psychiatric disorders are extremely high. So for instance, among detained youth, they report rates of psychiatric disorders anywhere between 60 to 70%, versus 14 to 20% in the general population among peers who have no history of detention. Unfortunately, detained adolescents also have higher rates of sexually transmitted infections. For example, gonorrhea rates among youth who have a history of detention are 10 times higher than adolescents who have not had a history of incarceration or detention. Few studies, however, have looked at detained adolescents, although they represent a highly vulnerable population, both in terms of mental disorders and sexual risk behaviors. And no studies have really looked at adolescents in detention as it relates to sexual risk and use of psychotropic medications. Now, we know in the United States that geography matters. So, for instance, there are growing rates of sexually transmitted infections among adolescents in the southern United States, as opposed to those in the eastern seaboard. So, where you live matters in relation to coming in contact or coming up with an STI diagnosis, and there are a lot of sort of structural and marginal issues related to this. Now, a few studies have begun looking at the relationship between being on psychotropic medications or having a mental disorder and higher rates of sexual transmitted infections. Most of these studies have looked at adult populations. And we know that age also matters because adults have different coping styles, they have different knowledge bases as it relates to sexually transmitted infections, and they may have also different types of partnering relationships. And we were really curious to explore whether or not adolescents who were on psychotropic medications, whether or not this was a protective factor against coming up with a biologically confirmed sexually transmitted infections. So researchers have speculated several potential mechanisms why mental illness might be related to higher rates of sexually transmitted infections. And we know for some populations, individuals may use illicit drugs as a way of self-medicating. Well, it's also speculated that some individuals may use sex as a way of self-medicating. So individuals who have high levels of anxiety may engage in higher risky sexual behaviors. Injection drug use is also higher among populations who have mental disorders. And it's also speculated that IV drug use may be one pathway, again, leading to higher rates of sexually transmitted infections. Many youth, as well as adult populations who have mental disorders, also report higher rates of homelessness. And along with homelessness, some individuals engage in survival sex as a way of staying alive in the streets. Institutionalization and detention is believed to disrupt important social and sexual networks. So if someone is in a partnering relationship or romantic relationship and they're incarcerated, well, that relationship is disrupted. And it may also lead to higher forms of casual sex. So there are lots of sort of reasons why it's hypothesized that mental illness is related to higher rates of sexual transmitted infections. So again, specifically, we were looking at an adolescent population, and over a 2-year period, we collected data at 8 regional detention facilities in the state of Georgia. We did weekly recruitment efforts of newly admitted detained youth and this resulted in an 82% participation rate. Adolescents were eligible if they were between the ages of 14 to 18 years old. They provided informed assent, and their parents also provided informed consent, and they reported having vaginal sex prior to detention. So these were some of the measures that we were interested in. We collected all measures using audio-computer assisted self-interviewing techniques, and as you know, this is a method that helps to reduce problems related to literacy. So the students answer the questions on their laptop, and they have a voice-prompted track that reads the questions to them. So we collected measures on race, ethnicity, whether or not they identified as white, black, Hispanic, or other. We collected information on age and length of time in detention, and these were in fact variables that we control for in all regression analyses, because we know age matters, race matters, and length of time in detention, and number of detention experiences also matter. So we also collected information on psychotropic medication use by asking them 3 questions. Are you taking doctor-prescribed medication? Are you taking doctor-prescribed meds to make you feel better? And are you taking doctor-prescribed meds to calm you down? If an adolescent said yes to any of these, we compared the medication that they were taking under Micromedics healthcare system, and we specifically looked at medications to control anxiety, affective and disruptive disorders. These we label as psychotropic medications. Participants who were not prescribed psychotropic medications prior to detention were labeled as non-PTM users. So again, we were looking at psychotropic medication use prior to detention, as well as sexual risk prior to detention. We also looked at self-reported measures in terms of, in the past 2 months prior to being detained, were you high or drunk during sex? Did you have group sex? And did you have penile vaginal sex without condoms? We also tested adolescents using the Abbott assay test for chlamydia or gonorrhea. So we use statistical procedures, univariate analysis control to describe the overall sample, bivariate analyses to look at relationship among major variables, and logistic regressions to look at the relationship between use of psychotropic medication and sexually reported STIs, controlling the age, gender, and ethnicity. So these were some of our results. The average length of stay was 14 days, and this is pretty consistent across most detention facilities in the United States. Average length of stay is anywhere between 14 to 18 days. 1 in 5 participants reported psychotropic medication use prior to being detained. Psychotropic medication use was higher among females versus males, 28% versus 17%. And psychotropic medication use was higher among whites than non-whites. 18% tested positive for sexually transmitted infections. All right, so this is a description of our overall sample. So almost half of the population was female. The majority of youth were between the ages of 16 to 17, and approximately 40% identified as white. So, controlling for covariates, we saw that folks who were on psychotropic medication use had almost a little over 60% decreased odds of reporting a biologically confirmed STI. And one of the reasons we wanted to look at biologically confirmed STIs is that very often youths don't know whether or not they have a sexually transmitted infections, in part because some of these diseases are asymptomatic or there's underreporting. So we really wanted to get a closer classification by using biological markers. And we found that youth who had been prescribed psychotropic medications prior to being detained reported lower odds of sexually transmitted infections. Being male was also a protective factor. Fewer males reported STIs, and again for biological reasons, males are less susceptible. minority status, if you were non-white, you had a 2.7 times higher odds ratio of reporting sexually transmitted infections. And interestingly, we found in other studies that although minority youth may engage in actually less risky sexual behaviors than whites, they have higher rates of STIs and HIV, and we call this the STI paradox. And what we're finding is that within minority communities, there tends to be a higher viral load in terms of sexually transmitted infections and HIV. So that your risk of becoming infected with HIV or a sexually transmitted infection depends upon which community you live in and who you have sex with. So if you have sex with a race concordant partner, someone that looks like you from the same ethnic group, because there's a higher pool of STIs within minority communities, your chances of becoming infected are higher. So this statistic, 2.7 times, sort of makes sense. And in part, there are lots of sort of structural, educational, and poverty factors related to this in the United States. Being male, males were 2.7 times more likely to report multiple sexual partners having group sex. Again, not surprising. So prior studies indicate that 2/3 of detained youth have mental health disorders. In this population, we found that a fewer percentage of youth were actually on psychotropic medications. Girls and minorities have higher sexually transmitted rates than their counterparts. And again, this is sort of consistent with general prevalence rates in the United States. We were not able to look at PTM compliance. We looked at whether or not it would prescribe medication. Future studies would have to look at compliance, and we know that this is a big problem across mental health disorders, that individuals may be prescribed medication, but compliance is very low. Convenience sample limits making causal inferences in these relationships. And in the United States, again, policies related to STI testing in detention facilities vary by states to states. So this is really, literally, you have a captive order. It's 2 weeks average length of stay that adolescents in detention. This is really an opportunity to engage in testing and provide them with important STI information. Again, we know that there are a lot of direct and indirect costs associated with STI infections, that kids who have higher rates of STI infections also have higher rates of mental health disorders, and there are all sorts of implications for their partners and sexual networks once they're released back into the community. Okay. Thank you.
Thank you very much for this very clear presentation. Do you have any question? Yes?
I wanted to ask, how did you know which medicine they took and what were the doses? Did you ask their names somehow, that you could go to database, or how it was? Because the question is, did they put right answers about partners? Was it good feeling for them to answer these questions?
Right, so once if they answered yes to any of these 3 questions and they were taking medication prescribed by a doctor, then we asked them, what sort of medication they were taking, and then we compared it with the micromedics classification system. So if it was medication to control anxiety, affective or disruptive disorders, then it was classified as a psychotropic medication. Most of these kids, they know that they are meds, and they know what the medications are. Sometimes they're not able to recall the information correctly. But again, this is information that we can verify, and we verified with their parents.
So it was only like one-time data points that you collected, or like?
Yes, so this is cross-sectional, so it was one-time data point, yes.
You look at the psychotropic medication, but if someone receives psychotropic medication, he probably has some mental illness. So how can you be sure that it's not the mental illness that is a protective factor? So because it's anxiety, depression, so people may be less at risk to engage in sexual
Great. Well, that's what we sort of speculated. Some types of mental illness may actually decrease sexual drives, or may present with certain types of symptoms that may make someone less attractive to a sexual partner. Right? Say if someone is acting sort of odd, that might not necessarily be a common for some potential sexual partners. So all these are factors we need to sort of disentangle. And in addition to sort of longitudinal data to track these clients over time. But controlling for their mental diagnosis was something we also put into the equation.
Okay, are there any further questions? Oh yes, okay, the last one.
So do I understand correctly that taking psychotropic medication reduces the risk of venereal disease?
Right. For kids who were on psychotropic medication, there was a lower likelihood of reporting a sexually transmitted infection, so they were correlated. Again, we can't assume causality because it was only cross-sectional data, but we did find it protective for kids who were on medication. For kids who expressed a need, that they had a need to have their medication, their behaviors controlled, and they were actually on medication, prescribed medication, that they had a lower odds of sexually transmitted infections. Yes.
So then psychotropic medication are good to use in terms of reducing the risk of...
Well, in this population, but again, this is a highly clinical population, and a clinical population that we know tend to have a high need for medication and also a high need of mental stress diagnoses. So for this particular population, yes. It's not something we'd suggest everyone in society.